All right. Welcome, everybody, to this edition of Let's Talk, presented by the Visiting Nurse in Hospice for Vermont and New Hampshire. As always, I'm your host, Anthony Knox. And this month, our presentation is going to be about Alzheimer's disease and all of the different facets of the disease that you should know about. Hopefully be able to answer any questions that you may have about the disease and any sort of treatment options and things like that. But I'm very fortunate to have Dr. Tawana here with us. She is the neurologist for Mount Ascutney Hospital. And Dr. Tawana, I'm going to hand it over to you just to be able to talk a little bit more about yourself and your background leading up to being at Mount Ascutney Hospital now.
All right. Thank you so much, Anthony. Hello, everybody. My name is Harmanpreet Tawana. I'm a board-certified neurologist and clinical neurophysiologist at Mount Ascutney Hospital. I did my residency training at Penn State Hershey Medical Center in Pennsylvania. After that, I finished my fellowship in clinical neurophysiology at Dartmouth. And right after, I started working here as the neurologist. And it has been a pleasure serving this area.
Awesome. So we're going to dive right in. So let me get the presentation up here. And for those of you watching this live, feel free in the comment section on the YouTube page to ask any questions, and Dr. Tawana will be able to answer them as we go. For anybody who is watching this not live, just streaming it on YouTube, if there are any questions, please don't hesitate to leave your comments there, and we'll make sure that they get to Dr. Tawana to be able to answer. So take it away.
All right. Thank you, Anthony. So today we'll talk about Alzheimer's dementia. So before we begin, a little bit about the organ, brain. As everybody knows, it's a very vital organ. It weighs about 3 pounds in the average adult, and it's about 60% fat. Remaining 40% is a combination of water, protein, carbohydrates. So it has main 3 structures, as you can see here: cerebrum, cerebellum, and brainstem. Cerebrum, which is front of brain, it comprises gray matter, which is the outer cerebral cortex also called, and the white matter is at its center. So this is largest part of brain, and it has further 4 lobes: frontal, parietal, temporal, and occipital. So frontal lobe, this is the largest lobe of the brain. It's located in the front of the head. It is involved in personality characteristics, decision-making, movement, and it also has a very vital area called Broca's area associated with how we speak, or how fluent we speak. Then comes parietal lobe. This is middle part of the brain. It helps a person identify objects and understand spatial relationships, like where one's body is compared with objects around the person. Then comes occipital lobe. That's at back part of the brain. That is involved with vision. Then temporal lobe, sides of the brain. So temporal lobes are the main lobes that are involved in short-term memory. And it also has a very important area called Wernicke's area, which is associated with comprehension, how we understand things. And so now coming to a very important question: what is cognition? What does it mean in simple terms? So it is defined as the mental action or process of acquiring knowledge and understanding through thought, experience, and the senses. And what are the cognitive domains? So we have 4 main domains of cognition: executive function, which is controlled by frontal lobe; memory, controlled by medial temporal lobes, and a very important structure in the temporal lobe is called hippocampus. Then language, controlled by frontal lobe, and visual by occipital, and spatial by parietal lobe. And this diagram here shows us, again, the same lobes: the frontal, parietal, occipital, and temporal. So cognitive decline can happen due to a number of reasons, and dementia being the primary cause, but there could be other causes too. Some medical issues, a person suffering from liver, kidney disease, thyroid issues, deficiencies in vitamins, especially vitamin B12, can cause cognitive decline. Then some neurological disorders, which are not dementias, but can cause cognitive decline, include trauma, a tumor in the brain, MS. Then psychiatric issues, depression being the primary. It can alone cause cognitive decline or with dementia. Then delirium in general, many causes, drug-induced, alcohol, recreational, some medications. Then what we are going to discuss today is dementia. We have 4 different kinds. There are many actual different kinds, but 4 main categories of dementia, which includes Alzheimer's, vascular dementia, Lewy body or Parkinson's disease, and then frontotemporal. So talking about dementia today, what is dementia? So it is a collection of symptoms related to cognitive decline, and it can include behavioral and psychological symptoms. And the deficits must be severe enough to interfere with daily function and independence. How does it happen? Due to biological changes in the brain, and every different type of dementia has different cause. Today we are going to talk about Alzheimer's, and we'll go into detail about what's the cause behind it. And Alzheimer's is one of the most common cause of dementia. And mixed dementia, which is Alzheimer's and frontotemporal combined, is also very prevalent. So it is an umbrella term. So umbrella term used to describe a range of symptoms associated with cognitive impairment. And Alzheimer's is the most common out of all 4. Then talking a little bit about, phases of memory decline. So dementia sets in when quite long before the symptoms actually appear. So patients, initially, they're cognitively unimpaired. That slowly goes into mild cognitive impairment, then mild dementia, then slowly into moderate and severe dementia. So it progresses. It's a progressive disorder. So talking about our main disease today, which is Alzheimer's dementia. So in 1906, a German physician, Dr. Alois Alzheimer, first described this disease, and he called it as one of profound memory loss and microscopic changes. And today we call it as Alzheimer's dementia. It is a type of brain disease. Just as coronary artery disease is a disease of heart, this is a type of brain disease. It is caused by damage to nerve cells, which are neurons in the brain. It affects memory, thinking, behavior, and symptoms, they eventually grow severe enough to interfere with daily tasks. And it is not part of normal aging. The greatest known risk factor is actually increasing age, and the majority of people with Alzheimer's are 65 and older, but it is not part of normal aging. And it is a neurodegenerative disease, which means it's a progressive disease. It's going to slowly progress. And over here, it's just showing how a normal brain looks like. The outer structure is the cortex. You can see all the folds. In the Alzheimer brain, the folds are so less. And the ventricles, these are fluid-filled cavities in the brain. You can see how big they look. So these are some pathological changes in the brain that could be seen.
So Dr. Tawana, so prior to Dr. Alzheimer first describing the disease, were there other parts of this disease that other doctors had described and things about, but was it just Dr. Alzheimer's that kind of put it together, basically?
He actually, that's right. He actually put it together. It was seen by other doctors too, but it was put together by Dr. Alzheimer.
Gotcha.
He was the one who did autopsy of the brain, and he actually found I'll talk about it later, the plaques and tangles in the brain. We talk about it today. He was the first one to describe those at that time.
Gotcha. Okay.
Yeah. Yes. So he's been the pioneer. And then talking about prevalence of this disease. So it is unfortunate, but currently at this time, 6.5 million Americans are affected with it. And maximum are in age group of 75 to 84 years. Then comes 85 plus years. And this number is supposed to increase by year 2050. The number projected is actually 12.5 million. And so that's the prevalence of Alzheimer's. Then what are the risk factors associated with it? Age being a common one. Then mild cognitive impairment. People who have some cognitive impairment, even mild one, they are at higher risk than a normal person to get Alzheimer's. Then this certain gene, ApoE4 positivity, it puts you at increased risk as well. Then family history in first-degree relative, especially if younger onset. Then vascular risk factors, people with heart disease, diabetes, they are at higher risk. Then it has been, loosely linked that people who have low physical activity and low social interactions, they're also at higher risk. And then female sex in general have been, there's more prevalence in females than males. And then a very important topic is genetics and Alzheimer's. So I want to mention here that family history is not necessary for an individual to develop Alzheimer's. However, research does show that the person who have a parent or sibling with Alzheimer's, they're more likely to develop the disease than those who do not have a first-degree relative. And people who have more than one first-degree relative with Alzheimer's, they're at an even higher risk. And some genes that have been identified are ApoE, APP, SORL, and PSEN. And I will talk about these a little bit more later in the presentation. Then what is the cause? That's the main question today. What is the cause behind Alzheimer's dementia? So brain has 100 billion nerve cells or neurons. And each nerve cell, they communicate with each other with the terminology we call synapse. That's how one nerve cell connects to the other one. And here it's just a magnified view of how a synapse occurs and all the chemicals that lead to the communication. So group of these nerve cells, they have special jobs to do. Some people say that to do their work, brain cells, they work like small factories. So they receive supply, they generate energy, they construct equipment and get rid of all the bad waste. And cells also process and store information and communicate with other cells. So to keep everything running in a factory or in the brain cells, they require large amount of fuel and oxygen. And just like a real factory, there are backups and breakdowns in one system that affects the others and cause problems in other areas. So as damage spreads, the cells, the neurons, they lose their ability to do their jobs and eventually die, causing irreversible damage to the brain. Scientists, they are still not sure where the trouble starts, but we are implicating tangles and plaques. They may be involved in the pathology of the disease. And so tangles are actually proteins, and even the plaques, they are proteins. They've been named differently. Beta amyloid, they are the tangles, and tau protein is the plaque. And my next slide shows us a description, a graphic of, how a healthy brain neuron looks like and how a person with Alzheimer's dementia, their biopsy will look like. So the neuron will have some plaques. The plaques, they are outside the nerve cells, and the tangles, which are tau protein, they're inside the nerve cells on the neurons. And how do they play a role? What's the role of plaques and tangles? So scientists actually, they do not exactly know how they play a role, but most people, they develop some plaques and tangles as they age. But people who have Alzheimer's dementia, they tend to develop these proteins, abnormal proteins, far more and in a predictable pattern, beginning in the areas important for memory. So the temporal lobes, that's where they are finding evidence that that's where it begins. So that's how they are contributing. And they cause destruction and death of nerve cells that causes memory failure. And again, this is just a graphic of how a healthy, normal person's brain would look like and how a severe Alzheimer dementia person's brain image would look like, and how it's attacked by these tangles and plaques. So now this next slide talks about how do people present with Alzheimer's dementia? What are early signs and symptoms of Alzheimer's? So first one is memory loss that disrupts daily life. So one of the most common signs of Alzheimer's, especially in the early stage, is forgetting recently learned information. And so recently learned information is the key thing. There are other things too, like people will forget important dates or events and asking same questions over and over. Then next is challenges in planning or solving problems. So they may have trouble following a very familiar recipe. Suppose a person has always baked chocolate cake, and all of a sudden they forget how to, what are the steps behind it. Or keeping track of monthly bills. And they may have difficulty with concentration too. Then difficulty completing familiar tasks. So they have hard time to complete daily tasks. They may have trouble driving to familiar location like grocery stores, which they've visited for the last 20 years. All of a sudden, they're not able to do so. Then confusion with time or place. So people with dementia, Alzheimer's dementia, they can lose track of dates, seasons, passage of time. They may also have trouble understanding if it's not happening immediately. And sometimes they may forget where they are or how they got there. And then trouble understanding visual images and spatial relationships. They can have trouble judging distance and determining, the distance between the cars if they're driving. And then they might have problems with words in speaking or writing. They may have trouble following or joining a conversation. They may, call a familiar object or use with wrong names. Suppose they call watch a hand clock. So this is something very common that happens. Then misplacing things and losing the ability to retrace steps. So a person living with Alzheimer's dementia, they may put things in unusual places. They may lose things and be unable to go back over their steps to find them. They may accuse others of stealing too. And decreased or poor judgment, withdrawal from work or social activities. So they may withdraw from hobbies, social activities, or other engagement. And then changes in mood and personality is a big factor too. So they may experience mood and personality changes. They become suspicious, confused, depressed, and they may be easily upset at home with friends or when they are out of their comfort zone. One thing I would like to mention here, so as we grow older, we eventually notice some slow thinking and occasional problems. Very commonly, we forget where we kept our keys or important document. But this is, in person who ages, this is occasional. However, people who have dementia, they will have serious memory loss. They will have confusion and other major changes. And the family members, they are the actually first ones who notice these changes in them, then the person or patient himself or herself. And then coming to, stages of Alzheimer's. So Alzheimer's, as I've mentioned before, it's a progressive disease. So it worsens over time. Although the rate at which the disease progresses, it varies. On average, a person with Alzheimer's lives 4 to 8 years after diagnosis, but I've seen people living up to 20 years as well, depending on other factors. So the Alzheimer, it typically progresses slowly in 3 stages. We label them as early, middle, and late. So early stage of Alzheimer's, which is a mild stage, a person may function independently. He or she may still drive, work, and be part of social activities. Despite this, the person may feel that he or she is having memory lapses, such as forgetting familiar words or location of everyday objects, but it's not as significant. They'll be able to retrace. So common difficulties in early stages are coming up with the right word or name, remembering names when introduced to new people. And I would like to mention here that during the early stage, this is the ideal time to put legal, financial, and end-of-life plans in place, because person with dementia will be able to participate in decision-making at this stage. Then coming to middle stage. So at this stage, this is typically the longest stage and can last for many, many years. So at this stage, the person will require a greater level of care. So dementia symptoms, they're more pronounced. The person may confuse words, get frustrated or angry. They may experience changes in sleep patterns, such as sleeping during the day and becoming restless at night. And they have increased tendency to wander off and become lost. And they will demonstrate some personality and behavioral changes like suspiciousness and delusions. So in the middle stage, the person living with Alzheimer's can still participate in daily activities, but with assistance. They need some caregiving. And at this stage, the caregivers may want to consider respite care or an adult day center so they can have a temporary break from caregiving while the person living with Alzheimer continues to receive care in a safe environment. So it's very important to identify the stages. Then our late stage or severe dementia. This is the final stage of the disease. And individuals here, they lose the ability to respond to their environment, to carry on a conversation, and eventually they don't really have much control on themselves. And at this stage, they will require round-the-clock assistance with daily personal care. They may have severe confusion, and definitely they won't be able to perform any activities of daily living, including brushing or going to, their hygiene care. And they may not recognize themselves or family members. And during this stage, the caregivers, they may want to use supportive services such as hospice care, and to focus on comfort and dignity at the end of life. And
So one question I had, so obviously you had mentioned that, family, close friends are probably going to notice the changes in the stages of the individual and notice, some of, the top 10 list that you had. From your experience or from your research and things like that, is there a point where the patient themselves recognizes that something is wrong, or from your experience, is it more the patient doesn't think that anything is actually wrong and that they're fine and kind of fight, the acceptance of this disease?
Actually, I find it both. I do have patients where, family members will bring them and say, I think something's wrong with my mom or dad. Please take a look at the patient. Mm-hmm. And where, yes, patient will fight off that. Nothing is wrong with me. And then when I do the evaluation, yes, there are some discrepancies in their memory. And I do have some people actually presenting themselves too. So it's a wide variety how the presentation happens. So like I said, first most common, presentation is difficulty learning new things. So in that case, patients, they are cognizant of that and they would present on their own, but it's not always the case. many times I just get family members bringing them.
Gotcha. Okay.
So both ways. Yeah. So this is, again, just a graphic presentation, how a mild to moderate Alzheimer person's brain would look like. There will be shrinking of the cortex and the ventricles will be enlarging. The hippocampus, which is the deeper structure in the temporal lobe, this is the actual memory center, becomes smaller. And in severe Alzheimer's, there are more pronounced changes. So now coming to evaluation, like what do we do when a person with memory presents or the family member brings them? Very important to mention here that there is no single diagnostic test that can determine if a person has Alzheimer's or not. But physicians, usually neurologists, neuropsychologists, and geriatric physicians, in a multidisciplinary approach, they and some tools they use can help make a diagnosis. So a physician is going to take medical history during medical workup. The healthcare provider will review the person's medical history, including psychiatry history. And they would want to know about any current and past medical problems, as well as any medications. So medication side effects are a big thing here. So we always ask the patients or family members to bring the medications to the clinic. And during the evaluation, the doctor will ask key medical questions like, is there a family history of memory loss? And was it an Alzheimer's disease or other kind of dementia? Then as part of medical history, they'll do physical exam and diagnostic test. And then in the neurological exam, it's very important to see, are there other signs of any other neurological disease? Are there signs of stroke, Parkinson's disease, where people will present with tremors mainly? Is there a concern for a brain tumor or buildup of fluid in the brain? And some other conditions that may impair memory or thinking. Then as part of neurological exam, a depression screen is very important for people with memory decline. Then some specialized tests we do for dementia patients, they are mental cognitive status tests. So I have two examples, the MMSE and MoCA test. These are the two commonly used assessments in the clinic. They are scored out of 30. And score above 26 or 27 is considered normal. Mild dementia, people will usually range in about 20 to 24. Moderate dementia patients will have a score of 13 to 20, and severe will be less than 12. And on average, the score of a person with Alzheimer declines about 2 to 4 points each year. And we bring them every 6 months to clinic to repeat this test to see how they are, declining. So this is a template of mini mental state examination. And next slide, this is the Montreal Cognitive Assessment, or MoCA scale. MoCA is considered slightly better than MMSE. Reason is we get to know about executive functioning, which is a frontal lobe test over here in MoCA test. So then a little bit further on diagnostic testing, there is no dementia test panel. There is no blood test where we could send them to lab and say, oh, okay, this is positive, this is negative. No, we don't have anything like that. All the researchers are working on it very hard. So when a person comes with dementia-like symptoms, most essential tests are to obtain a thyroid test, vitamin B12, and brain imaging. American Academy of Neurology actually recommends some kind of brain imaging, be it CT scan or MRI. MRI is a preferred modality because it has better way of looking at the brain tissue structures. Then we may send the person to neuropsychologists, which are PhD doctors, And they do a very extensive memory testing. It's like 3-4 hours of testing they do, and they can help differentiate what kind of dementia the patient has. And then recently approved are these PET scans, which can help us differentiate different kinds of dementia. These are not commonly employed, though. They are expensive, and they are not easily available. Only tertiary care centers have these. And then a big question in today's world, genetic testing. So I would like to mention here that researchers, yes, have identified certain genes that increase the risk of developing Alzheimer's and other rare deterministic genes that directly cause Alzheimer's. So there are risk genes and deterministic genes. So risk genes, ApoE4, it's the strongest risk gene for Alzheimer's. This test is mainly used in clinical trials to identify people at higher risk of developing Alzheimer's. Carrying this gene mutation only indicates a greater risk. It does not indicate whether a person will develop Alzheimer's or whether a person has Alzheimer's. So very important to know that. So genetic testing in regular dementia patient is controversial and should only be undertaken after discussion with a physician or genetic counselor. And then a little bit mention on deterministic genes. These are the genes, if you're positive in these, yes, you will have dementia. It's a very rare kind of autosomal dominant Alzheimer's disease. And the genes that are implicated here are APP, PSEN. These are the main ones we test. And they account for less than 1% of all the cases of dementia. And they usually run strongly in families and tends to begin earlier in life, sometimes as early as 30s. And so that's about genetic testing. And then there are home genetic tests available these days as well. I would caution against using them. So you need to talk to a genetic counselor before deciding to take an at-home. Reason is, with an unsupervised at-home test, there is a real possibility of misunderstanding results, which could result in making misinformed decisions of your health. So unnecessary concerns. Then brain imaging, why do we get a CAT scan or an MRI as part of dementia workup? It's mainly to rule out other causes. Is there a tumor? Is there a stroke involving the memory centers of the brain? But there are certain, things we can pick up for people with dementia on the brain imaging. And main thing is cerebral atrophy, which is shrinking of the brain. So it's common in patients with dementia, but it's also common in normal aging. But we look at key things. Is the shrinking generalized? Is it all the brain? Or some parts of the brain have shrunk? So typically in Alzheimer's dementia, the temporal lobes and parietal lobes, they will shrink more than the surrounding region. So these are certain, very subtle things we can pick up on the brain imaging. Then coming on to the treatment of Alzheimer's. So unfortunately, there's no cure for Alzheimer's. But there are some treatments that may change disease progression and some pharmacologic and non-pharmacologic options that may help treat symptoms. So recently, FDA approved this drug called aducanumab. So they labeled this as drug that may change disease progression. So it is an anti-amyloid antibody. It's an infusion therapy. How it works by targeting beta amyloid plaques. So it cleans the brain of the plaques. And it is the first therapy to demonstrate that removing plaque, which is one of the hallmarks of Alzheimer's disease from the brain, is reasonably likely to reduce cognitive and function decline in people with Alzheimer's. So this drug was studied in people living with early Alzheimer's dementia. They did not conduct on moderate or severe dementia people. So further studies are needed for this drug. And definitely it comes with side effects. And one of the significant one is brain swelling. So that is quite a significant side effect associated with this therapy. Then there are other treatments. Then other treatments, they are only to mitigate some symptoms of Alzheimer's disease temporarily. And we'll talk in the next few slides about them. So these are drugs which came out a long time ago, and they target cognitive symptoms. They're not going to, cure you of any memory issues. They'll just slow the progression of memory decline. And so they help with lessening or stabilizing the symptoms. Out of this, the most common one which we usually utilize is donepezil, or comes with brand name Aricept. It has been approved for all the stages of Alzheimer's, whereas galantamine and rivastigmine is approved for mild to moderate dementia. And then memantine and memantine plus donepezil, we reserve it for people with advanced dementia. Almost all of these drugs, they carry with them GI upset, nausea, vomiting, loss of appetite. They will have weight loss. And they also carry with them a side effect of delirium or confusion and dizziness. So these are some, adverse effects associated with these drugs. And there are treatments for non-cognitive symptoms. And as you know, Alzheimer dementia patients, they do not just have memory issues, they have behavioral and psychological issues. And person's quality of life will be impacted more with behavioral and psychological symptoms, such as sleep disturbances, agitation, hallucinations. So at this time, the FDA has approved one drug to address symptoms of insomnia. And that has been tested in people living with dementia, and it is Belsomra or suvorexant. And it has been shown to be effective in people, but carries side effects. It impairs your alertness, and it can worsen depression or suicidal thinking. So it can also compromise respiratory function. So it's not routinely given. And some treatments for behavior. So we do give other things which are actually off-label. Off-label is a medical practice in which a physician may prescribe a drug for a different purpose than the one for which it is approved. So we commonly put the patients on antidepressants, anxiolytics for people with anxiety or who have really disruptive behavior, and lorazepam or Ativan is a common one to be prescribed. Then antipsychotic medications for hallucinations, delusions. They are like clozapine, quetiapine, or Seroquel. These are commonly prescribed. Then, very important to mention, non-pharmacological measures. And I think these are of utmost importance here. So caregivers should be told about what are the coping tips. How can we, monitor personal comfort, check for pain, hunger, thirst. If a person is really thirsty, they may behave very differently. So look for underlying cause behind it. Do they have some kind of infection? And the room they live in, is the temperature comfortable enough for them? And avoid being confrontational. So they could argue about facts. And sometimes for example, if a person expresses a wish to go visit a person who is, dead, and so do not point out that that person is dead. Instead say, that person is a wonderful person. I would like to see her too. We will go there together. So reorient them rather than, rather than being confrontational there. And then redirect the person's attention. Create a calm environment at home. And try to remain flexible and supportive by responding to the emotion and not behavior. And look for reasons behind each behavior. And if a caregiver thinks that a person is behaving like that after a certain medication was introduced, let them know, reach out to the physician. And do not take the behavior personally and share your experiences with others. And then maintaining regular times for meals and for going to bed and getting up. And morning sunlight exposure, make sure all the blinds in the room are up, and letting the natural light in is very important. And then encouraging regular daily exercise, even if it is like a small walk outside in their community. Then avoiding alcohol, caffeine, these are excitogenic things, and nicotine is important. And treat pain. And if the person is taking, these drugs for memory, donepezil, rivastigmine, avoid giving the medicine before bed. I usually tell my patients or caregivers for the patients to give it earlier in the day. And provide night lights and security objects. And if the person awakens at night, discourage staying in bed while awake. Use the bed only for sleep. So these are some non-pharmacologic measures we can do to help these people. Then there has been some evidence that, Mediterranean diet, which is a diet rich in colorful fruits and vegetables, it may help, slowing the progression of the dementia. And then exercise, especially aerobic exercise, 20 minutes, 3 times a week, may prevent the progression. And mentally stimulating exercises, doing crossword puzzles, Sudoku, there is plus and minus evidence there for how they can help. But I usually encourage my patients to keep doing that. So alternative treatments, you might come across, if you Google for dementia, there might be some remedies which are not FDA approved, but they label it as for dementia. So although some of these remedies, they may be valid candidate for treatment, but since there is no FDA approval for the drug for these kind of supplements, I would always caution against them. There are a lot of supplements out there which people, say that they help with dementia. I will just go over some. So a very common one that my patients bring it to me is huperzine A. This is actually a moss extract that has been used in traditional Chinese medicine for centuries. It does have properties similar to those of cholinesterase inhibitors, which is the class of drugs, which is donepezil. So as a result, it is promoted as treatment for Alzheimer's disease. But the Alzheimer's disease cooperative study, they conducted a large-scale U.S. clinical trial on huperzine A. And the result was they experienced no greater benefit than those taking a placebo. So there wasn't any major evidence signifying that it does help. Then coconut oil. Some people, tell me about coconut oil, but there hasn't been enough clinical testing of coconut oil, and there's no scientific evidence that it actually helps. Then coenzyme 10. So they did test its synthetic version of this compound called idebenone, but it did not show any benefit either. And then coral calcium, ginkgo biloba, and this tree is ginkgo biloba tree. NIH had conducted a multi-center phase 3 clinical trial on ginkgo, but again, it did not quite show any evidence in preventing or even delaying the Alzheimer's disease. And then research. So scientists actually have made quite a big amount of progress in understanding how Alzheimer's affects the brain. But ultimately, the path to effective therapy or treatment is through clinical studies. Issue we are running is recruiting and retaining trial participants is now the greatest obstacle. other than funding. We are getting good amount of funding, but retaining people or patients in the study is a big challenge. So I encourage people to, go onto website for Alzheimer's Association. They have a trial match. It's a free clinical study matching service, and you can participate in the research. So these are some resources and support group: NIA Alzheimer's and Related Dementias Education Referral Center, Alzheimer's Association, Alzheimer's Foundation of America, National Institute on Aging Information Center, and Elder Care Locator. So the thing is, why get checked? Why, when you don't, people come and tell me, if there is no treatment, why should we get checked? So medically, getting checked by your doctor can, first of all, help determine what's causing. Is it really dementia? If there's other cause. And when you are diagnosed with dementia early in the disease, there is a good opportunity to participate in clinical trials. An early diagnosis makes individual eligible for a wide variety of clinical trials. And there's another thing, very important, a chance to prioritize your health. So some lifestyle changes like controlling blood pressure, stopping smoking, participating in exercise, it may help preserve cognitive function. Then emotional and social benefits. Receiving an early diagnosis may help lessen anxieties, why you're experiencing these symptoms. And you also have the opportunity at this time to maximize your time with your family and access resources and other support programs. And then time to plan for the future. Planning ahead allows you to express your wishes about legal, financial, and end-of-life decisions. And you'll be able to, discuss finances and property and identify your care preferences. So that's very, very important as to why to get checked, why get the diagnosis. So having said that, this is the end of the Alzheimer's dementia presentation, and I'm open for any kind of questions.
So first off, thank you so much for that entire presentation and everything, from, beginning stages, kind of what to expect, some possible treatment modalities, just across the board. Awesome. Thank you so much for all of that information. One question that I should have asked way earlier in the presentation, but, we'll kind of come back to it now. So you had talked about genetics partially being a part of the conversation as far as, if your, mother or father, sibling has dementia, you're potentially more likely to have the disease. Has there been any studies or review that it's more prevalent if your mom's side of the family has it or your dad's side of the family has it, that, potentially could impact yourself or your sibling or something like that in relation to the disease?
It's actually a very good question. I never thought about that, and I don't think so. I've come across anything, whether paternal or maternal. That's what you're asking, right?
Yes.
Whether paternal or maternal genes play a different role. I really do not know about that. No. Okay. It's usually, we generally say family in general, sibling, parent, they put you at a higher risk, but it's not definite risk either.
Right. And are there any studies around that it skips a generation, kind of thing? Like there's some diseases where, my grandfather, and I'm not gonna lie, this is very much like a very personal conversation or question for me. My grandfather about 6 years ago ultimately passed away because of Alzheimer's and also had Parkinson's disease as well. And I mean, obviously from my perspective, and it's my maternal grandfather. Okay. So from that perspective, I mean, as far as, and obviously I'm paying probably a lot more attention towards my mom, in that respect, as far as, for
any signs,
which then, for myself. But, but is there anything around like, it skips a generation or anything like that? Or I mean, again, the other piece of it too is that, and this is a complete assumption, that somebody who had it, maybe they're the lone wolf in the family of having it, and it doesn't impact anybody else in the family.
It does happen like that too. So key thing is environmental factors as well. And sometimes it's not Alzheimer's dementia. It could be vascular dementia. People who have really bad control of vascular risk factors, which is high blood pressure, having bad glucose control, high cholesterol, it can impact brain. It can cause what we call as a white matter disease, and that could also cause dementia. So it depends on environmental factors too. And yes, you could be a lone wolf in the family and have the disease and nobody else could have it.
Okay. So basically, I mean, there could be additional medical reasons that nudge somebody into a form of dementia. Gotcha.
Correct. Yes.
Okay. Excellent. Outside of that, I'm not seeing any other questions currently, but again, if there are any questions after this, for anybody who is streaming this after the presentation, all of the comments, there is an email that gets triggered to the visiting nurse in hospice for Vermont, New Hampshire, that we would be able to connect you with Dr. Tawana. She can also be reached at Mount Escutney Hospital. Just call the main number. They can hook you up with being able to chat with her. And so outside of that, Dr. Tawana, I want to thank you so much for taking the time out of your busy schedule to do this presentation and provide us with just a wealth of information about Alzheimer's dementia.
Thank you for having me, Anthony. It was a great pleasure.
Awesome. And for everyone else, be on the lookout for our next presentation. That'll be happening sometime in July. We'll post it on our social media as well as on the listserv emails for the towns that we serve. And for anybody who has any topics that they'd like us to discuss during these Let's Talk presentations, please reach out to me at the Visiting Nurse in Hospice, and we'll work on getting a presentation set up for you. So, but again, thank you so much, Dr. Tawana.